Morning, colleagues, ladies and gentlemen. Welcome to this session, Lung Cancer Access and Ablation. I'm Bing Lan from Hong Kong. I'm the chairperson of this session, and I have a co-chair, Dr. Pyng from Singapore. She will also chair this meeting and also introduce the last two speakers. As you can read from the title, Access and Ablation, when we talk about lung cancer, talk about ablation, most likely we are talking about small lung cancers. And for small lung cancers, how to diagnose is always challenging. And today we have three excellent speakers. We will talk about how to diagnose for small lung cancers and also treatment of small lung cancer via bronchoscopy. And I would like to introduce our first speaker, Dr. Terence Tan. Dr. Terence Tan currently works at Queen Mary Hospital, University of Hong Kong, in Hong Kong. He is the Associate Consultant of Queen Mary Hospital. He's also the Honorary Clinical Assistant Professor, University of Hong Kong. Terence is trained in intervention pulmonology, and he has a lot of experience in doing diagnostic procedures and therapeutic issues, including thermoplasty for asthma and also lung volume reduction. Today, he's going to talk about transparenchymal lung nodule access, TPBNA. Without further ado, Dr. Tan, please.
Thank you. Let me share my screen. And so, can everybody see this?
Yes.
Okay. So I have no particular disclosure relevant to this talk, and I'm going to start. So today I'm going to talk about full lung access with virtual bronchoscopic navigation. And for the next 15 minutes or so, I'm going to cover for the general audience, why is bronchoscopic navigation gaining importance over the years? What are the common types of navigation platforms out there? And through some case sharing to illustrate when VBN could be the preferred platform for some of the cases. And bronchoscopic navigation is basically navigation techniques or technologies that help an operator access the target within a lung parenchyma. And you can see from the data that was reviewed from the Nelson trial, the nodules that we are interested in, as Pyng had mentioned, are small nodules and they lie in the periphery of the lungs. And so navigation is essential, and it goes very much hand in hand with periphery bronchoscopy because we want to get to these lesions. And platforms are usually those that involve some form of computer-aided system that helps the operator get to these lesions. And not to be too shrouded in mystery, these bronchoscopic navigation are just ways to help us find a pathway that hopefully avoid major structures so we don't hit the lung, the heart, and major vessels so we don't hit aorta, the SVC, and we don't hit the pleura. Otherwise, we would have just gone for a CT-guided FNA. And so naturally, anatomically, the airway just provides us with a very good way to get to these targets that naturally avoids all these structures. And so the airway, if the airway reaches our target without having to go through any of these, then we'll call these targets those with positive bronchus sign. And this would then involve just a natural conventional transbronchial biopsy. And if somewhere along the pathway, it involves some form of breakage of the airway wall, then if it is just next to the lesion, then we would do some TBNA, so we use needle. And if it's somewhere even further off, then you can call it tunneling, you can call it cross-country, you can call it BTBNA, off-roading. It's just a name. The important message I want to get across from this slide is that this is just two steps of the same process. It should not be treated as two separate techniques that you have to learn, and operators should not be too apprehensive towards this last step. If we want to have a full access to all the nodules in the lung, this is part and parcel of what we have to do eventually. whichever it is, this step one takes most of the pathways, and because we want to get to rather close to the target before we need to consider this. And we want to do this through well planning, because if we don't, and we see this year after year with our trainees, they want to wing it, and then when they wing it, this is what happens, and we have to pick up the mess. And the reason that people keep trying to improvise and think that they can just go in and improvise is probably because of one of three reasons. First, they feel that it doesn't seem to be a problem with like some of the conventional transbronchial biopsy cases. And it is often true when you have large lesions. As long as you point it into the right direction, the randomness probably and the large biopsy tissue probably compensates for the relatively lack of inaccuracy. As the lesion gets smaller, then that gets to be an issue. The other reason, common reason, is people feel that if they started using a radio EBUS with guide sheath, then their accuracy would improve. And it's true that if you get a positive signal, then it would improve. But if, of course, on the converse, if you don't get a radio EBUS signal, then obviously you're not going to get an answer. In fact, this is most often the common reason that when bronchoscopists started using radio guide sheath technique, some of them that get very discouraged because there is an actual initial drop in their diagnostic yield very early on. And finally, there are some that feels that when I get my hands on an ultra-thin scope, they'll improve my maneuverability, and I can go further and I can move around more with more control, and I can get to my lesion. And again, that is true if you're very good with operating your C-arm and you can see the target. But as you get further and further and the target gets smaller in a moving lung, then sometimes you don't get to see these. And it gets, not only do you receive a lot of radiation, it gets harder and harder to see this lesion. And of course, your accuracy drops. So whatever it is, pre-planning of some sort helps you overcome much of these issues. And these pre-planning, there are more than one way to do it. Overall, there are the manual methods and there are the computer-aided method. Bottom line, these are the typical cases that we would consider doing a lot of pre-planning before we go in. And truth be told, these can all be approached through both different platforms. Manually, the strength is that it's more tolerating to poor qualities in terms of the CT requirement, but it takes months and years to learn, and there might not be an end to how much you can learn more, although the learning curve plateaus. And it's operator dependent, so you get good days, bad days. Sometimes you can be quite off if you have a bad days. For VBN, EMB, those platforms, and you're rather consistent. So for this particular platform, if you do it manually, then of course, what we mean by manually is that you look at the chest CT, you draw the airway, and then you predict which way is where, and then you go in and then you find your way until you get to the lesion. VBN uses a technology that uses the CT data, and then they render the airway into a pattern, and then they recognize the pattern, and then they guide you to the target. And finally, electromagnetic navigation uses a GPS-like system. They localize the target within the 3D plane by electromagnetic field, and then they guide the sensor that you're going to put into your bronchoscope, and then they try to guide you to guide the sensor to approximate the target and thereby effectively guide you to the system. So when people know that we have access to all three types, then the natural three questions that they ask are the following. So how does the navigation platform help me further? And I'm already pretty proficient with manual navigation. What factors determine the suitability of a case for VBN versus EMB if I'm going for a computer-aided system? And the third question is, if I want to buy a system for my hospital, should I go for VBN or should I go for EMB? Now, of course, these three questions can take up a whole symposium, but for a short 15-minute talk, I'll try to answer this question with three case sharing in the following slides. This is a case with a 61-year-old lady that has been heavily pretreated and is now on osimertinib. She has a right lower lobe lesion, and this consolidated mass has been responding. There's only one particular spot that has been SUV increase in SUV uptake, so there's differential response. We know that it's not too difficult to get to this particular consolidated mass, but to get to this particular part in which we want to get the NGS to see whether there's a resistant mechanism, we want something more. And for the VBN platform, there is a function that allows us to plan a puncture site and then plan our trajectory so that we can specifically get to a part within a certain area of a consolidative or a part of the lump. And this helps avoid vessels, etc. So classically, this is called bronchoscopic transparent nodal access, in which you puncture the airway wall deliberately, avoiding vessels, and then you do dilation, and then you introduce a guide sheath or sheath system through the airway and then through the lung to your target in order to gain access. The classical bronchoscopic transparent nodal access, or BTBNA, involve the use of a therapeutic scope and therefore a proximal puncture site near the third or fourth generation. It uses a dedicated balloon dilator and a larger sheath. And because of the distance, the narrower margin of error, especially for more distance target, and accounting for some breathing movement, it needs deep sedation and calibrated C-arm to ensure accuracy. Nowadays, we're doing a little bit more of this mini BTBNA in which we use the pediatric scope so that we can get nearer to our target. And then we do the same puncture, but then we try to force a radial EBUS guide shift through. And thereby, because we're closer, we can have a wider margin of error nearer to the lesion, and the level of sedation and C-arm, the calibrated C-arm becomes optional. And for this particular lady, this is exactly what we did. We first approached it just like any other radio EBUS case. And not surprisingly, we got to the target and there was positive radio EBUS signal. But then on the fluoroscopy, it did not match the virtual fluoroscopic site as we want it to be. And so we converted immediately to the mini BTBNA pathway, and we punctured through at the planned site, went through a tunnel of 11 millimeter, and then we forced the guide sheath through and then pick up a signal, and then we did the biopsy there. Between different platforms, this is another case, an 83-year-old man with a liposarcoma that was resected, and the post-op CT showed that on the contralateral side, there's a left upper lobe lesion that needs to be sampled eventually. Now, this is the CT that was loaded into the system. And we know that by the time that we need to sample this, either way, the effusion might have been resolved because of possible post-operative change, or it might not have been resolved. If we do this with an EMB system, then we need to consider CT to body divergence, because there are multiple reasons that contribute to CT to body divergence. But for those that are not familiar, it simply means that the time of acquisition of the CT contributes to, and the difference of the time of the bronchoscopy contributes to a shift in the position of the target. And if you do this with EMB, it can cause an issue. For this particular patient, by the time they come back in to do the procedure, there's no more effusion. But because the target is an airway link target, LB1+2A2, And so with the VBM platform, it will still be able to guide us through matching the pathway and guide us to a lesion without any issues. But perhaps the most important use of the VBM platform is this. These type of lesions, I would tend to believe it depends on your interest in these navigation technology or navigation bronchoscopy as a technique. In a typical respiratory unit, your dedicated person that you go to, and this is the versus those that are interested, versus there are always other colleagues that are interested in other aspects of respiratory medicine. And a typical respiratory unit have this kind of staff ratio. And based on staff ratio, they take up different workload in terms of needing to go in and do the grunt work of diagnosing these nodules. And when we ask our centers, just their subjective confidence in making diagnosis of these, considering all factors, I would say I will be able to make this case 80% of the time. Our trainees at 65%, considering all patient intolerance, everything included. Other colleagues would say 50%. I might not be able to get to it, etc., etc. And this makes an interesting math when it comes to it. Overall, after excluding all the cases away from those that you would refer for CT-guided FNA surgical biopsy, because of the weighted diagnostic yield, the overall diagnostic accuracy of our unit as a whole becomes 50, almost 60% only. And if you can introduce something that have almost no running costs like a VPN system, then we can finally be able to offload a lot of these cases to our other colleagues, and our other colleagues will feel confident that they can do these cases and give a positive diagnosis. And this makes a difference. And the difference can be quite marked if you put it into numbers. These are the unofficial audit that we showed with the improved, after utilizing VBN. These are the improved in the diagnostic yield. And you can see that the number that benefits, you give me a lot of platforms and I will be able to improve my yield by 9% every 1,000. But if you give it to the others, the improvement is a lot more. And the improvement in numbers are quite significant. So in this short 50 minutes, I hope I have briefly touched on and answered these three questions. And that's the end of my talk. Thank you.
Thank you, Terence, for the excellent talk. And if there's, we can leave the Q&A session at the end of this whole session. Yes, Pyng, please introduce.
I think we get on to the next speaker. The next speaker is Professor Shiyue. He's the Deputy Director of the Guangzhou Institute of Respiratory Health. He's also the Director of Respiratory and Critical Medicine, the first affiliated hospital of Guangzhou Medical University. He's always at the cutting edge of technology. So today we are very delighted to have him share his experience on bronchoscopic radiofrequency ablation to treat lung cancer. Professor Li?
Yes, thanks, Pyng. Dear guys and the audience, let me share the screen. Okay, can you see that? Can you see the pitch, the screen? Can you see the screen? Can everybody see the screen?
Yes, yes, we can.
Okay. Hi, everyone. It's my pleasure to share our study. My topic today is the transbronchial radiofrequency ablation study to treat lung cancers. And this is my disclosure. And as we know, in the lung cancer is the first position of the malignancy tumor. In China, here we can see there this study is from Chinese CDC. It shows that now the lung cancer is the third cause of the death in China. And as we know now, the peripheral lesion detected in CT and screen are increasing. So the peripheral lesion is very common in our clinical practice. And as we know, now the peripheral lung cancer is about 30% of the whole lung cancer. And for the remedy for of the peripheral lung cancer, we can use the surgery, radiotherapy, and percutaneous ablation and transbronchial ablation. Here's the SBRT, the result in this paper published in 2016. It shows for the lesion less than the diameter less than 2 centimeters, the 5 years survival is about more than about 85%. So for the SBRT, it seems the good therapy for is a good method for treating the lung cancer. Here's another paper just published this year. The data is so that is the it's the retrospective study. The data from the USA from the NSCLC. So the inclusion for the I think this is two different group. One group is received the treat with the SBRT, and the group is received the treatment with the radio frequency. The number for the RFA is 191, and the patients for the SBRT 6,004. So compared to this, the result of this different treatment, here we can see the results since the time limit. So we move to the results. For the diameter for more than less than 2 centimeters, the result seems favorable to the RFA, and for the lesion diameter more than 2 centimeters, the efficacy is favorable to the SBRT. So this the data. This data shows that for the small lesion, the radio frequency is the quite good result. And as we know, this is for the this method, the radio frequency is detected under the guidance of CT percutaneous. So as we know, the frequency for the transbronchial ablation in the treatment the peripheral lung cancer this is the key factors. First, the navigation guided precise to the nodule, and the ablation techniques include the thermal or vapor, cryoablation, drug injection, and seed implantation, and combined therapy. The different now there are many different navigation methods, just as mentioned by Dr. Tam, include the X-ray guidance, VBN, EBAS, and bronchoscopy robot, and the other methods. As we know now, the CBCT is getting more and more more and more common in the clinical practice. And also for the VBN is also is the regular method for the clinical. And another method, BTPNA, that was developed by Dr. He in 2015, is the new technique to the nodule that the bronchoscopy size is negative, and the mechanism as Dr. Tan described. And as we know, the bronchoscopy robot is now is also a new technique. And for the ablation technique technology, includes radio frequency ablation, microwave ablation, cryoablation, laser, and vapor, and the others. So today I will focus on the radio frequency. As we know, the radio frequency is currently the most widely used ablation techniques for the treatment the solid tumor. And for as we know, like this showed in the center, the center area, the high temperature cause coagulative necrosis of the tumor tissue in the target area here in the center. For the peripheral or transitional area, it will stimulate the body to produce specific antibiotics, thereby killing or inhibiting tumor growth or spread. Here the mechanism of the radio frequency ablation. The other technique for the peripheral lung cancer include the vapor ablation. This technique, this is so that through the tester, the vapor can with the temperature about 65% of the vapor into the bronchus, and then will induce induce the necrosis here. So here we can see here the necrosis area, and here's the picture show the uniform necrosis. Is the preclinical data source. For the bronchoscopy radio frequency, this is the first paper, published paper in 2007. It shows that under the EMB guidance through the bronchoscopy, so the radio frequency can with the output power is 20 watts, and 3 times for each patient. And here we can see the diameter of the lesion is about 1.5 centimeter. And the studies also show that no obvious complications occurred. So for this study, we can see this method is feasible and safe, but the efficacy is limited since the necrosis area is just 1.5 centimeter. The necrosis area is limited. In another study published by a Japanese colleague in 2015, also under the CT guidance, and the radio frequency is the cooled radio frequency ablation. So it's totally 20 patients included, and 25 lesions was treated. It's the CT guidance bronchoscopy guide low temperature radio frequency ablation. Here's the catheter. This is the one case after the treatment. This is the lesion before here, so the lesion here and before ablation, and 3 months later after the ablation, and 24 months later, and 36 months later. And the results show that 11 lesions was significantly reduced, and 8 lesions was stable, and the local control rate was 82.6. For the 5 years, overall survival is 61.5, about from 36 to 87%. So the conclusion for this study is for the stage 1 NSCLC that is not suitable for surgery. CT guided bronchoscopy cool radio frequency ablation can be considered as an option. And our team is focused on the ablation for the peripheral lung cancer from 2018. First, we used the under the assistance of BTPNA and the CT in the CT image. We used the regular radio frequency RF of the ERBI from ERBI is the regular radio frequency. We did the 3 cases after treatment. At the same time, the patient received the surgery. So from here, we can see the necrosis about also 1.5 centimeter. It's also the necrosis area is also limited. And then we work with the American colleague on the new equipment. Here's the equipment. Here, there's a balloon stop the bronchus, and then and the tip here, there's a very micro pore, and the system can induce through the mini pore to the with the 10% of the saline to increase the heat expand. So this another new equipment for this equipment now is study in this group was is doing the clinical trial in Australia. here we can see the in the in vivo. Here we can see the lesion is bigger than the regular one. It seems about the 3 centimeter the diameter. And then we China we develop another new system. Also here here's the another this is the equipment. So there are many mini pore, and we at least keep the saline can insert to the this pore, and then we'll cool down the local temperature and let the heat expand more blow. And also their sensor here can detect the temperature, and then we'll have the shape to control the power. Here's the structure. We can see here the structure. Now we did the overall study and in vitro study, and here's the 3 months data. And also we did the dose and effect the area curve, and this work was published in Respiration. Now and then we start a clinical trial with the topic is multi-center single group target value clinical study on the safety and efficacy of the radiofrequency ablation system in the target of the peripheral lung cancer. The total size 129. Here's the inclusion criteria, and there's the exclusion criteria. It is the study workflow. And now we have received almost 90 cases. Here's the data about of the first 69 patients. About is a patient about the propagation of the no stage of the pulmonary lung cancer. Here's the lesion size and the pathology, and the procedure time is about 35 minutes. And the completion is so far no severely severe adverse events related to the device. Here's the 9 SAE curve for the study. Then let me see some cases. This case is before the treatment, and then we use the VTPNA and assess the target, and then we under the CT guidance, and then we have the ablation. 24 hours after the ablation is 30 days and 6 months the CT image. Another case is also the lesion at the right upper lobe. We also use the BTPNA to target the lesion, and then before and after 24 hours after CT, and we can see here 1 month the cavity here, and then 3 months the solid lesion here. Yeah, we can see the assess the ablation, the case that assess to the ablation. And here we can see another cases here. So for the summary, peripheral lung cancer is the main field of the main field for the interventional pulmonology. Transbronchial radiofrequency ablation in the treatment of the peripheral lung cancer has initial shown its safety, feasibility, and the efficacy. Okay, thank you.
Thank you very much, Professor Lee, for the excellent sharing of your excellent experience with the RF catheter. We'll keep to the questions to the last. I'd like to invite the next speaker, Dr. Daniel Steinfort, who's an associate professor at the Royal Melbourne Hospital. He also has a lot of interest in lung cancer as well as early ablation technologies for early cancers. He has authored more than 130 medical articles on lung cancer and respiratory disease. So we welcome him. He'll be talking with us on bronchoscopic treatment of peripheral lung cancer using the vapor ablative technique. Dr. Steinfort.
Thank you very much, Pyng, and thank you to the conference organisers for the chance to present this data. This is clinical data from a recently completed first-in-human study examining use of bronchoscopic vapor ablation for treatment of peripheral lung cancer. As Professor Lee was describing, there are a few options for peripheral ablation of lung cancer, a few methodologies or modalities. This is one that certainly has some appeal because of the ease of localization. However, I'll present the specific data in our first-in-human trial. The data I'm going to present is a combination of work from colleagues in Austria who undertook the initial clinical first-in-human studies, and then we've recently completed a clinical feasibility study, which I'm going to present. In way of disclosures, this work was supported by a grant with no specific individual remuneration from Broncos Medical. So in way of background, we all obviously know that bronchoscopic tumour ablation has growing interest and that there are a number of devices in development. All of these are newly developed devices for treatment of ablation of peripheral lung cancer. However, bronchoscopic thermal vapor ablation has been established for many years now, given it was initially used quite successfully for bronchoscopic lung volume reduction. And so the concept of delivering vapor ablation to a large extent of lung parenchyma is not new, and the safety profile of this is relatively well established. For treatment of peripheral lung cancer, the intent was to use a higher amount of energy to a smaller volume of lung to achieve complete necrosis rather than just injury. And so the catheter was modified to allow positioning and delivery of the vapor ablation at 2 to 3 segments beyond, more peripherally than the initial bronchoscopic lung vapor ablation catheters. There was preclinical and ex vivo data published prior to commencement of our studies that demonstrated that the peripheral ablation was well tolerated, and then there was uniform necrosis within the treatment zones once a specific energy threshold was reached. Importantly, the ablation zones appeared to be very well anatomically contained. There was no significant leaking or leaching of thermal energy to other parts of the lung. The BTVA system that was used for this study is illustrated in the bottom right of the slide. There was essentially a steam generator which was delivered via a handpiece attached to the delivery catheter. We undertook pre-procedure planning using the Archimedes system to derive a virtual bronchoscopic pathway to the target lesion. A target dose of 330 calories was delivered over 8 seconds. For the 5 patients that constitute this study, we used radial EBUS to confirm on-target delivery of energy towards the tumour. The eligibility is relatively predictable. So these were patients with biopsy-confirmed non-small cell lung cancer with the target lesion being less than 2 centimetres, and both the lesion and the patient were considered candidates for curative resection. Importantly, in this study, this was a treat and resect protocol. And so following ablation, 5 days following ablation, the patients underwent standard of care surgical lobectomy for their for oncologic management of their tumour. The 3 initial in-human studies were completed in Vienna, as I mentioned, and these were patients underwent ablation and resection within the same anaesthetic procedure. There was one adverse event in this group where a patient underwent a wedge resection which did not contain the tumour. And so for this reason, beyond moving forward into the treat and resect study conducted at Royal Melbourne Hospital, we elected to use lobectomy routinely. In the clinical feasibility study, this was completed in Melbourne, Australia, as I mentioned, and treat and resect protocol dictated that surgical resection was performed within 3 to 5 days of the BTVA procedure. We enrolled 6 patients in a 6-month period, and there were no significant peri-procedural complications observed. One patient had transient pleuritic chest pain and development of a right-sided pleural effusion, both of which resolved with conservative management after 48 hours. There was one of these 6 patients who tolerated single lung ventilation very poorly, and so the resection was not completed in this patient. And so the other 5 patients constitute the rest of this report. These patients underwent resection at a median of 5 days. And just looking at their clinical data below, you can see there was a range of ages and sexes, and lesion size varied from 9 millimeters up to 17 millimeters in maximal cross-sectional dimension. All of these were part solid lung adenocarcinomas with pleural contact in at least a few cases. The treatment was were all on the right at varying levels of generations, and the generation there is from the lobar bronchus. So these are in fact, so 4th generation, for example, corresponds to in fact a 7th order airway. 4 out of the 5 patients, as I mentioned, had their tumour position confirmed via radial endobronchial ultrasound. You can see there was some variability in the energy delivered, mainly based on whether patients received 1 fixed dose or 2 fixed doses in adjacent bronchi. And apart from the first procedure, which took some time, you can see the treatment duration was in fact very short on average, apart from the first patient, 11 or 12 minutes. It was technically a very straightforward procedure. At the bottom of the slide, I've presented 2 illustrative cases. One patient, which is the patient in the second column here, had a part solid lesion in the lateral right middle lobe, which underwent bronchoscopic thermal vapor ablation. And you can see a well-defined ablation zone surrounding the tumour, which has also developed some central cavitation. And this CT scan is performed 24 hours after the BTVA procedure. You can see that the ablation zone is very well defined and has a margin of hemorrhagic necrosis around it. And this is the patient that also demonstrated a modest inflammatory pleural effusion in response to the BTVA. Another patient here has a part solid right upper lobe lesion with pleural contact. And in this case, you can see that the ablation zone is not quite as uniformly defined. And there's also some suggestion perhaps that the tumour is sitting right on the edge of the ablation zone. So this is the patient, 4th column here, so 5th order airway. So there would be some concern based on that CT that there was not complete inclusion of the tumour within the ablation zone. Here are some intraoperative and gross histologic images. So the image on the left is a thoracoscopic image of the right middle lobe deflated here in the middle with a significant area of pleural blanching over the pleura. And this, in fact, is the patient on the left here. So you can see this area here is the area that demonstrates the pleural blanching on thoracoscopic imaging. However, the overlying parietal pleura was unaffected. Here is from a different patient, a resected tumour that sits well within the ablation zone. The tumour is noted by the black arrow, and there is significant, there's obvious and uniform necrosis macroscopically around the tumour with, again, a rim of hemorrhagic necrosis surrounding the ablation wedge zone. In 4 of 5 patients, there was a uniform ablation zone seen. And the one patient where there was not a uniform ablation zone, we think this was for technical reasons. Delivery of the energy was only done at a 2nd order airway rather than a 4th or 5th. And so the volume treated was much larger than the other 4 patients. We believe this was the key factor in inadequate ablation zone in this patient. For tumours positioned within the target ablation zone, there was 100% necrosis achieved. And so the key for this appears to be adequate targeting of the ablation zones to the tumour. We achieved 98 and 100% ablation of tumour in 2 cases. The remaining patients had some small varying from 10 to 30% viable tumour. And the main issue here was that this area of tumour was positioned outside the ablation zone. This suggested to us that perhaps increased number of ablation doses during the procedure would potentially improve the success rate of the procedure. We've published these results earlier this year in the Respiration Journal. We also had some add-on studies which demonstrated that there was an increase in PD-L1 tumour proportion score, so PD-L1 expression in 3 of the 5 patients, which did not appear to correlate with standard measures of systemic inflammation. And again, this was reported earlier this year in Translational Lung Cancer Research. We're now continuing work looking at the potential for achieving an immunogenic response in patients as another therapeutic measure in this group. So our conclusions from this talk are that bronchoscopic thermal vapor ablation for treatment of peripheral lung cancer is certainly feasible and is very well tolerated by patients. Accurate targeting of tumours by ablation, so keeping the tumour within the ablation zone, is critical to therapeutic effect. The distal delivery of thermal vapor does result in very well-defined treatment areas with uniform necrosis. And on this basis, we believe it's quite clear that there is the significant potential for minimally invasive tumour ablation using bronchoscopic thermal vapor ablation, which, as I mentioned, is technically a very straightforward procedure. There are further larger scale studies planned to confirm these findings. Thank you, Pyng. Thank you, everyone. I'm very happy to have been able to share the talk. And happy to take any questions, but they will come through you, Pyng. Is that correct? And
I just clicked on the slide that says questions, and there seems no open questions from the audience.
May I ask a question, Pyng?
Huh?
May I ask a question to Dr. Steinfort?
Sure.
Yes, Dr. Steinfort, excellent talk. I would like to know what is the average duration of vapor treatment for, say, a 1.2 centimeter tumor? How many seconds?
So so how many seconds for the actual treatment? So 8 seconds.
8 seconds, I see.
Yeah, so the energy is delivered over 8 seconds. And then obviously, depending on the size of the lesion and depending on how well it is. So we used EBUS to determine if we are completely on target or whether the airway was very eccentric to the lesion, in which case it might be useful to then treat the adjacent airway. And so obviously another 8 seconds in that case, but it was a fixed period, fixed 330 calories of thermal energy delivered over 8 seconds.
And the tip of the catheter should be within, what is the maximum distance from the target, the tip of the catheter?
Our intent with this study was to have the catheter sitting as peripherally as we could. And so part of the inclusion criteria with this study was that the lesion had to be in the outer 50% of the lung field. So it had to, we tried to get as distally as we could, positioning the tip of the catheter just at the edge of our bronchoscopic vision.
I see.
So we didn't deliver energy beyond bronchoscopic vision.
I see. Thank you.
I think the biggest challenge is really to confirm the diagnosis of cancer before you actually do the vapor ablation, because unless you have all the technology and the tools, most of the time, I mean, quite a significant proportion of the time is that we cannot get the diagnosis of the nodule before we can even treat them. So what might your what might be the proposal to do that, you know, because in your study where you did vapor ablation, all of them had confirmed cancer before you actually treated them, meaning that possibly there's an airway leading to the nodule, and that allows you to biopsy it, and then it allows you to treat it subsequently. What about those that are eccentric nodule where you can't even get the diagnosis? If you vaporize it, then subsequently, if you do the lobectomy, even though they have speculations and they look very suspicious for malignancy, people can still argue that, you know, the necrosis and the scarring may be a benign scar to start off with, and you're not actually dealing with tumor. I think that is the major problem that I am encountering. I mean, I would like to hear the panel's opinion as well.
Yeah, in our case series, we had 3 of the patients that required CT biopsy to achieve a diagnosis. Particularly for a clinical trial, we were concerned initially if we did achieve 100% necrosis, right, and we had not confirmed malignancy beforehand, yes, it could be said that perhaps there was no cancer at all. Right. So we needed that to be able to determine that we had achieved a clinical endpoint. I think if this does in the future, if it does become more established, there is a precedent in in radiotherapy where they will offer empiric radiation to lesions that are very small and are high risk for biopsy if the imaging characteristics suggest a very high likelihood of malignancy. And whilst I think there is more parenchymal injury as a result of BCVA because the ablation zone is larger, it actually is, as I said during the presentation, it's technically, I think, much less challenging. It's really sort of point in a segmental airway and deliver the energy. So in that sense, it is much easier it's almost easier to deliver the therapy than it is to achieve a biopsy. There may be even a role for small concerning lesions, particularly ground glass lesions, to just have vapor ablation and then continue CT surveillance if they're too challenging to achieve a biopsy for.
Right. So the ones that you have CT guided TTNA of the nodule, did they get more complications from the vapor, or it's about the same whether you reach it bronchoscopically?
We didn't see a difference, no.
Okay.
May I ask a question?
Yes.
Is there any data on these type of vapor ablation to tumors after you use these modified smaller catheter? What is this lung function loss? Is it after the ablation? Is it a lot less? Is there numbers that we can quote to the administrators?
Part of the protocol was actually to complete respiratory function testing on the day prior to surgery. So we do actually have that, and I apologise, I don't know that off the top of my head, but I don't know the exact figures, but there was not a significant change in FEV1 or DLCO. So there was very marginal, and for I think 4 of the patients there was no appreciable change.
Thank you. And another question is, it was quite appealing when Professor Hirth was talking about, I think everybody knows especially from the combination, about dual ablation, first doing whatever, microwave, RV, and then do the vapor, especially for solid tumors. Any thoughts from the other 2 speakers about any worried about first doing RFA and then with the amount of desiccation, and then that would affect the subsequent vapor, whether the vapor would now be unable to vaporize or to treat the pre-treated RFA more solid component. Would this be naturally a synergistic treatment, or would that eventually might just work against each other if we put the two together? What are the thoughts?
Professor Lee, what do you think?
I think the combination may be the method for the further, but I think we should study the single method first, see which method is the efficacy and the safety, even the area of the necrosis, and then we can see whether we can combine different methods.
Thank you.
And turn on the mic.
Probably need to close. We are kind of over. Thank you all speakers for the very excellent talk and the excellent sharing of the data. Bing,
Yes.
you want
Please
to close?
No, please close this session, please.
Okay, all right. Hopefully we can see each other next year in Seoul,
Yeah.
in person. All right, thank you very much.
Thank you.
Bye.
Bye.
Thank you, everyone.
Bye bye.
Bye.